So welcome back after a post-lunch session, and we thought that we won't discuss physiology. We'll go towards more practical points so that we should make you awake and not sleepy. So when we talk about all the physiology, basically it is for three purposes, either for ovulation induction, IUI, or when it comes to IVF. So now we are going to just look upon that how we can apply the same physiology in our day-to-day practice. So I'm just covering about the non-IVF stimulation. So first lecture I'm covering about ovulation induction cycle, and the another one will be IUI part. Ovulation induction, anyone, everyone is doing, all of us, and even though we have ultrasound machine, though we not have, but I'm not going to discuss a very minute details of ovulation induction, but what problems we face when we are doing simple things, and then how we should go about. So this is what the total the session is going to cover. So we'll just go from smallest thing, how the letrozole will act. So letrozole mechanism of action is, it is an intra-ovarian action where there is a lower E2, and that negative feedback mechanism will go to hypothalamus and pituitary. So there is increase in the intra-ovarian androgen because letrozole is a aromatase inhibitor. And with that effect, there will be FSH increase, and that will have a dominant follicle, and that will make the follicle, that will make the cycle ovulatory. But one of the additional point or advantage of having letrozole, that letrozole also extends the, it increases the L-selectin and integrin expression in the endometrium. So it is not only for the ovulation purpose, but letrozole has a good action on endometrium also. So letrozole in stimulation, specifically even in HRT cycle also has been tried, so that it will improve upon the L-selectin and integrin level in the endometrium to have better implantation of the embryo. Clomiphene citrate, it is selective estrogen receptor modulator, and we know that it is having a hypothalamus pituitary axis where it sits on the receptor for longer time, and that will increase the FSH and LH. So it is basically making that aware that E2 is on the lower side, and because of that there will be increased amount of FSH and LH. So with clomiphene citrate there are two isoforms, Zu and N-cyclophene. Out of that, N-cyclophene is having longer life. So it occupies estrogen receptor on the hypothalamus and pituitary, and this negative feedback mechanism will have release of GnRH, and that will increase FSH and LH. So we are going to just see the difference between letrozole, intra-ovarian action, clomiphene citrates, hypothalamus pituitary action. Letrozole monofollicular development, and clomiphene citrate, it is multifollicular development, because once the receptor sits over there, it occupies the receptor for longer time, so it is widening the FSH window. In letrozole, it is short acting, the effect won't last more than 38 to 40 hours, so there is a monofollicular recruitment because the FSH window is not that wide in letrozole compared to the clomiphene citrate. And one advantage of letrozole is it increases the integrin expression, but being SERM, clomiphene citrate is having antagonizing action on the endometrium, so we may face thin endometrium in patient with clomiphene citrate. Now this thin endometrium clomiphene citrate is not very common. When we are giving these cycles of clomiphene citrate continuously, then somebody may face, or there could be an individual variability. In first cycle itself, the patient can have thin endometrium. But many times once we give trigger, we we don't see the patient post trigger to look upon the endometrial thickness. So the simple thing is to ask that how much she had bleeding in last cycle. If she had spotting, means for this particular lady, maybe clomiphene citrate is not going to be useful because it is having antagonist action on the endometrium. Letrozole, no such side effects are there, and with thin endometrium, even the cervical mucus become hostile in clomiphene citrate compared to letrozole. So protocol conventional, we all know that we either start from day 2, 3. In PCOS, if the lady is unovulatory, she is not getting cycles without withdrawal, you can start even day 10 of the cycle, just do a sonography, see the endometrium is thin, and both ovaries are quiet, you can still start ovarian induction at that particular time in PCOS. So this is a standard protocol which we use in PCOS patient, unexplained infertility. and clomiphene resistant cases, where we see on day 10 of the follicle, day 10 of the cycle, if the follicle is beyond 18-19 millimeter, then we give HCG trigger. Now whether to give trigger for letrozole is 95% of the letrozole ovulation induction cycles are self-ovulatory. So it's not mandatory that every letrozole cycle has to be triggered with HCG. You can always monitor after, once the follicle is dominant, you can always monitor the lady at day 20 or 21 of the cycle. If she is having spontaneous ovulation, she need not have HCG trigger in every cycle. Now at times when we all know that for PCOS, letrozole is the best drug for ovulation induction. But sometimes whenever the PCOS is resistant and with your 5 days of letrozole is not working, these 5 days of letrozole had come from clomiphene citrate only, because initially the clomiphene citrate was given for 5 days. From the same background, now the letrozole story has started, and even the letrozole is given for 5 days. And we all know basically letrozole started to have as a cancer therapy in breast, to lower the estrogen, and now we are using it for ovulation induction. So the basic mechanism is to decrease the estradiol, but when it is not responding to for 5 days, then in those patients, rather than immediately going for gonadotropin, you can go for extended letrozole protocol in resistance PCOS patient. Many of the time you may see that with 5 days they are not stimulating, but with 10 days of letrozole, what you are doing, that you are again continuously suppressing the E2, widening the FSH window. So the FSH threshold, which is not overcome with your 5 days dose of letrozole, that will be overcome by this extended letrozole. You give it for 10 days, and then day 12 onwards you can do the scan, and again you have a trigger criteria.
Why don't you start on day 3 in extended letrozole also?
We can start day 2, day 3, day 4, any time, because PCOS hai, so you can start at any time. Even for normal, if she is responding to 5 days of letrozole, need not go for extended letrozole in that case. This is mainly we see in patient with PCOS, where 5 days of letrozole is not recruiting the follicle. In those patients, next time. But that you can give on day 2, day 3, day 4, any time. Just confirm that endometrium thin and ovaries are quiet. So about letrozole endocrinology, when we compared, we know that once there is a clomiphene citrate, CC, which is on the receptor, it is going to pump in FSH and LH continuously. But we also should know that LH has a better LH surge. And the physiology behind that, the letrozole initially will be having very low estradiol. Now what is going to happen, more amount of FSH and LH is going to come. So post letrozole, once you stop the letrozole, now the receptors are hungrily waiting for the amount of estrogen which is going to be generated by the dominant follicle, and that will give a reflux to the hypothalamus pituitary ovarian axis. So amount of LH which is released is more, and that is why LH surge, LH levels in letrozole cycle is better, at par or more than in compared to clomiphene citrate. So in even along with LH surge, also the progesterone is having a better increase in letrozole cycle, and this is with the physiology that we all know that progesterone is getting converted into androgen by 17 alpha hydroxylase enzyme, and then androgen is getting converted into estradiol with aromatase. Now letrozole is being aromatase inhibitor, there will be increase in the androgens. Then because of this blockage of estrogen and increase in the aromatase activity, there is a backflow. So more amount of androgen, more amount of progesterone. That is why we see high estrogen level, high progesterone level when letrozole cycles are there. Then that's why whether we should support, let's say if either you can, whether to give trigger or not, that I already explained that 95% it will self-ovulate. But if we give trigger, then whether we have to support. But what we understood just now, that LH has a very good progesterone rise, so need not support the luteal phase when we are your induction of ovulation with letrozole. So there is a scientific conflict, but Cochrane says no for luteal phase support when you are giving letrozole ovulation induction. And with AMIGO studies, more pregnancies in letrozole IUI group, which has high progesterone level, and no pregnancy when the progesterone was less than 5 nanograms. So this was a controversial thing that Cochrane is saying no for the luteal phase support when you are doing ovulation induction with letrozole. But when they have done a retrospective analysis of study of AMIGO study, they found those who are having less progesterone level in letrozole ovulation induction cycle had very less pregnancy rate. So to have that, whether we should consider about luteal phase support is dilemma. But whatever data we have now, we are practicing no luteal phase support when it is letrozole ovulation induction cycle, even if we are not giving. It's a monofollicular development. If it is a multifollicular development, when we may give. Advantage of letrozole, as we saw, that good LH search, spontaneous ovulation, no need of strict monitoring, and better for remote patient. Let's say you have a PCOS girl who is irregular cycle. She has just married for 1 year, and we know that her cycles are unovulatory. Other than that, there is no other parameters where you evaluated other semen analysis of the partner. You can just put her on letrozole, ask her to have timely intercourse during that period. No need of monitoring, because we are certain that there will be ovulation. We just monitor 1 cycle and confirm that she is responding to letrozole. Then you can put her on letrozole for 1 year also. That is also okay, because that increases her chance of pregnancy, because you are making her ovulatory from unovulatory cycles. No need of luteal phase support. PCOS, definitely letrozole is the first choice. If it not responding to letrozole, then the second is to go for gonadotropins other than clomiphene citrate. In unexplained infertility, when they have done letrozole versus clomiphene citrate in unexplained infertility study, the clomiphene citrate has better outcome compared to the letrozole. The reason could be the low E2, or the clomiphene citrate, which is making multifollicular development. That could be the reason, but it is just a hypothesis. They have not given a explanation that why clomiphene citrate has a better hand over letrozole in unexplained infertility. Low ovarian reserve, clomiphene citrate is a very good drug, because that take your FSH threshold very high. So in low ovarian reserve patient, if you have a patient of 0.5 mH with FSH which is borderline, clomiphene citrate will be a drug of choice. The only thing is you have to call the patient for follicular monitoring little early, rather than calling day 10 or day 11 later, because these patients having short cycles, they will be having a faster recruitment. So on day 8 or day 9 only, the follicle can be of 16 to 17 millimeter, where you can think about giving trigger for this patient. Avoid clomiphene citrate if there is a thin endometrium or history of scanty menses. Clomiphene citrate protocol, we know we go by step dose, but standard dose what we start with 50 milligram for 5 days from day 2, day 3 of the cycle, and then ultrasonography and the trigger criteria you all are very well aware of. Now there could be a scenario that there is a PCOS lady and you had given her letrozole for 5 days, and on day 10 there is no recruitment. There is no follicle which is beyond 10 millimeter. Now you have to tell that girl that you are not responding. So next time you go for gonadotropin, or now we consider as day 1 of your stimulation, then add gonadotropin. But that is going to increase her expenses. And this is for the first cycle we are experiencing everything. That may have some negative impact psychologically on the patient. So in this patient, if she is not responding to letrozole, what we can do is Stair-step protocol, where we can give clomiphene citrate, where you are giving the 5 doses of clomiphene citrate continuously 12 hours apart of 50 milligram. Then again call her after 5 days. Many times they will respond to clomiphene citrate, because whatever intraovarian androgen has been accumulated with letrozole, that will be an additional factor, though the follicle is not recruited. Now the FSH threshold you are increasing for that particular follicle, and you may see recruitment when there is a stair-step protocol. You can do with 50 milligram every 12 hourly 5 doses, or you can decide depending on her BMI. If she is very obese, you can give 100 milligram also, depending on the characteristic. So then you can repeat the sonography, and when the trigger criteria is fulfilled, then you can go for trigger. So this is one advantage where we can avoid gonadotropin and we can have a stair-step protocol. Now, this was a concept which was introduced by firstly by Brode Hustal, that where we can combine letrozole and clomiphene citrate together. So we have a advantage of both the things. So we don't have antagonizing action of clomiphene citrate on the endometrium. Plus we are intraovarian increase in the androgen level. So combiningly, we can have that advantage of both the ovulation induction agent, increase the FSH threshold. So from day 2 or day 3 of the cycle, you start letrozole 2.5 milligram once a day for 5 days. And along with that, you can add clomiphene citrate at the same time, 50 milligram continuously for 5 days. So if you combine, as I told, that it will increase the FSH threshold and you may see a better recruitment. So this was last week only, one of the fellow in our one discussion, she was mentioning that initially she had a patient where she was not responding to letrozole. Then she gave CC also, she was not responding to that. And then instead of going for gonadotropin, they combined both clomiphene citrate and letrozole, and that lady had dominant follicle. So this may happen that instead of immediately going for gonadotropins, we can combine clomiphene citrate and letrozole. That will to have a better recruitment. When they have, again, this was a study about, I was talking about Meja et al. Only the thing is, this group, when they had combined this clomiphene citrate along with letrozole, they had compared with only alone letrozole cycle, and 10% additional had conception in this particular group, and better pregnancy rate than individual drugs alone. So we may think of, rather than immediately going for gonadotropins, to have this bridge in between to see whether the patient is having recruitment or not. Now, whenever we talk about gonadotropin cycles, so let's say you have tried with letrozole, you have tried with clomiphene citrate, or either with combined, but still the patient is not having good recruitment, and you want to go for gonadotropins. So ideally, it should be go low, go slow protocol, where you are just giving 75 units of HMG every day, and follicle monitoring is to be done every 5 days interval to see whether the recruitment is there or not. But at times, these doses will be still smaller, and you may have to go for higher dose, but again there is a risk of OHSS. So Mitwali and Casper were the first author who combined these ovulation induction agents along with HMG, and they found if we add clomiphene citrate or letrozole along with HMG, it decreased the amount of gonadotropin which we need for having a recruitment. So from that evidence, we always have, whenever we are doing control ovarian hyperstimulation, either with timely intercourse cycle or IUI cycle, we either combine the cycles with letrozole or clomiphene citrate. So letrozole 5 milligram from day 2 to day 6, and then you have a choice of adding these gonadotropins from day 4 onwards continuously. Whatever we have seen in our clinical practice, that 75 IU dose is very low for at least in Indian scenario. Those in Western countries, they always say that 75 units is better, but many of the time their studies are with Menopure or Gonalef. So when there is recombinant dose, or maybe that ethnicity will have maybe having a low requirement of doses. But what we have seen is in our clinical practice, whenever we are giving letrozole along with HMG, we give it for 5 days. Then from day 4 onwards, we give continuously HMG for 4 days, and then call her on day 9. We'll see what is the recruitment. If the follicle has already recruited, but it is less than 16 millimeter, then we may give 2 more doses of gonadotropin continuously. And then when the trigger criteria fulfill, we can give trigger and go ahead. And this is mainly useful in patients when we are doing IUI, where we are we don't want monofollicular development. We prefer that there should be 2 or 3 follicles to be recruited to have better success in this particular group. Now about COH and TIC IUI cycle. So treatment physiology, when we talk about control ovarian hyperstimulation, either TIC or IUI cycle, that with monofollicular development, our outcome may suffer, but improve this mild ovulation problem like delayed development, inconsistent ovulation. So ovulating normally, but simply does not conceive, that can have additional. So I'm talking about unexplained infertility. They are ovulatory people, but still we want to improve the chance what your letrozole or clomiphene citrate is going to have additional effect. So in those patients, it's better to add gonadotropin so that you have multifollicular development that will improve upon the success. FSH addition increases estradiol, optimizes the cervical mucus plus endometrium, and that supports the follicular growth. And HCG ensures adequate luteinization. FSH addition merely stabilizes an already functional process to a satisfactory woman. So from that angle, we have moved from ovulation induction. If she has been taken it and we know that she is ovulating but still not conceiving, then we can move towards COH TIC cycle with addition of FSH or gonadotropins. So when we are knowing that this lady is already ovulating or unexplained infertility, then it's better to add gonadotropin, preferably recombinant FSH, because since LH is already there, unless she is a poor ovarian reserve patient. So you can start with 50 to 75 IU of starting dose. If the patient is older or she is having higher BMI, so instead of 75, it's better to go for 150. We may require some adjustment in between if you are seeing that she's not had recruitment with whatever dose we have started. And it's better to increase slowly rather than sudden increment in the dose, so that we should avoid hyperstimulation, and start stimulation from either day 4, 6 of the cycle and give it continuously for 5 to 7 days to have better recruitment. So low dose of RFSH or Menopure, high dose we may require for many patients. And PCOS, Menopure work better, either in IVF stimulation also, but obviously it becomes very expensive to offer Menopure when it comes to COH TIC cycle or IUI cycle. So we use our urinary preparations of HMG. Low reserve or age more than 35, Gonalef and this Menopur may work better. Now these are the again agents which are for IUI. So in IUI stimulation, when we think about having a protocol, then what simple protocol we follow? Because many of the times all of us should accept that we are doing many of IUI for our unexplained infertility patients, where they are still ovulatory and not achieving pregnancy, then we move towards IUI. So in these patients, our main aim is to have multifollicular recruitment. So a simple protocol to follow is by which was been devised by B. N. Chakravarti, where from day 2 to day 6 you give 5 milligram of letrozole, and then on day 2 you give 150 IU of 1 HMG, and on day 6 you give another HMG of 150 IU. If the patient is coming on day 3, you can give again on day 3 or day 7. So what it's going to do, that your first letrozole is going to have intra-ovarian action, and it is going to increase certain amount of FSH. Your second day HMG injection is going to take that FSH threshold little higher. When you are stopping the letrozole on day 6 of the stimulation, then you are additionally giving the last dose of HMG. So that will improve the FSH level more, and that will have multifollicular development. So with this protocol, if you are forming 2 or 3 follicle, then this is the ideal protocol to follow. If with this protocol, this patient is not conceiving in IUI, no need of jumping for more injections and another brand, because she is having a really good response that you are having 2 or 3 follicles, which will be having a good result in terms of IUI. So basically it is for IUI, when or in where you are targeting more than 1 follicle, you can go ahead with this protocol. And who will be having good response for this particular protocol? The good responders, where with 2 HMG only they are having 2 or 3 follicles. Patients with donor IUI, because the wife is very young, she is having very good ovarian reserve. Patient with unexplained infertility, this clientele will have definitely good effect. Obviously those patients who are resistant PCOD, we may have to go for many doses of gonadotropin till the time the follicle is recruited. Yeah. So at times it may happen, as I was mentioning, that we are giving these 2 doses of gonadotropins. On day 10, the patient has come for follicular monitoring and there is no recruitment. Now you have to either have again that option, that either cancel the cycle, saying patient that this has not worked for you, from next time we will give continuously gonadotropins. But sometimes it's very difficult for the patient to accept again that I have come and in between only this has stopped, and that will put a negative impact. So what you can do, increase the dose for further 5 days. So on day 10 of the cycle, you are seeing with 2 HMG, which is not given a recruitment of the follicle. Now you give gonadotropin continuously for 5 doses and then call her again. Now with this thing, you can start even with 75 IU if she is thin, otherwise 150 IU depending on her BMI, so that after 5 days if you see there is a recruitment, then the gonadotropin dose will continue till the time the follicles become 17 to 18 millimeter. If there are 2 follicles and are going beyond 17 millimeter, we can still go ahead with trigger. The only risk is if suddenly you increase the dose with no recruitment, there is a possibility of OHSS. So for PCOS, it always go low, go slow protocol. So Western countries always says go for, they are to saying go with 37.5 and then you give it continuously. Indian ovaries are not going to respond to that at all. So many times we see in our practice that 150 IU is the dose what we start. And as you are rightly saying that all the papers mention that you give it till the time of trigger. Very difficult for the patient because of expenses, because how much we do, the IUI cycle result are not going to go beyond 15 to 18%. So from that cost effective point of view, we can definitely think about giving it alternate day or 4 days and then seeing what is the recruitment. So in patient with PCOS, severe PCOS, high BMI, high LH, low FSH, high AFC, difficult results, we may have to step up the dose, but increase by 25 IU rather than sudden increase in the FSH doses. And if you are giving injection and for more than 14 days, still there is no recruitment, then it's better to cancel the cycle, because it is going to have additional many expenses, and you are already given that follicular phase of 14 days, still there is no recruitment, then we may have to think of going with another protocol and starting with higher dose. And in these patients, it's better to go for drilling, because that is the, I don't even remember last when we have done drilling for any PCOS patient. But there are some difficult patients, where they are very young, all parameters are normal, but they still have to take a lot of gonadotropin doses to have 1 follicle recruitment. In these patients, we can think about going for drilling. Obviously, if these patients are having very high AMH, 15 or 20, with your drilling, it is going to be maximum 10. but it's not going to make much effect. So you have to choose or select a patient for LOD with a very specific criteria. In lean PCOS, LOD works very well, not in obese PCOS, because in obese PCOS, when their BMI is very high, even that and adipose tissue is going to have one more additional fact of estrogen, and that is going to again not having better impact. It's not that in high obese patient, if you do drilling, it is not going to make a huge difference. If the patient is not responding with your gonadotropin stimulation, in those patients also you can go for LOD. LOD will be having a better action for the the study has been published. So LOD will be having better result, not for the first conception but for the second conception. And if we think about LOD versus giving gonadotropins, the time to pregnancy interval is less if you go ahead with gonadotropin. So you have to choose your patient really well. If the patient is having AMH between, generally what we practice that if the patient is having AMH below 8 or 9, then they are a good candidate when they are having low BMI. If the AMH is very high, drilling ovary and taking just that AMH with 2-3 nanogram down, it's not going to make much effect, and again we have to go for treatment in this patient. So when it comes to whether we should really bother of thin endometrium in ovulation induction, because sometimes there is a nice follicle, specifically in letrozole cycle we may face this situation that you have a nice follicle of 19 to 20 millimeter, but endometrium thickness is only 5.8 millimeter or 6 millimeter, and then people are start with giving estrogen support, but that is not mandatory. That is not going to have any impact on the endometrial thickness whatsoever, because you are seeing the endometrial thickness on the trigger day. Now, if you really want to know that whether she really had thin endometrium, call the patient after 7 days, see her in mid-luteal cycle. If that on day 21 of the cycle, if she is having good endometrium, so definitely forget about that thin endometrium. Again, you can ask the patient that how much she had bleeding in this particular cycle. If she had good bleeding, then whatever you are seeing on the ultrasound, it doesn't matter and it is not going to contribute for her failure. So no exogenous estrogen, and mid-luteal endometrial thickness measurement will be better in patients with letrozole cycle. This we already discussed, like what are the cutoff of AMH on day 2 or day 3 also. These slides I'm just skipping. About atypical luteal phase dominant follicles, Sarah has already discussed. Residual follicle more than 20 millimeter, no role of OC pills at all. You can just, if the endometrium is thin, you can still go ahead. Then favorite topic is luteinized unruptured follicle. So what could be the reason of luteinized unruptured follicle? Either you had given trigger but she has not ovulated, or after giving trigger also the follicle is only luteinized but not ovulated. So for follicle to get luteinized, for follicular maturation, we need 5% rise in LH, that is 15 to 18 MIU of LH should rise for maturation of the follicle. But for ovulation of the follicle, it should be beyond 60 to 80. So many of the time there is inadequate LH rise, or inadequate, only surge is there, but that peak is not lasting for longer time, and that's why the follicle gets luteinized, but it doesn't get ovulated. So apart from this, there could be endometriosis, where the ovarian capsule is very thick and that is not allowing the mechanical rupture of the follicle. That's why follicle get luteinized but not ovulated. There could be some pelvic adhesions, again the mechanical problem, that it is not, it is making the wall thick and not easy to rupture. Then inadequate trigger, where the patient is very obese and whatever drug you had given for the trigger, it has gone just in her fat and it has not delivered intramuscularly. So whenever there is obese patient, it's better to give 10,000 IU of HCG with long needle deep intramuscularly, so that she should not have inadequate trigger. Then if at all you are giving recombinant HCG, better to give 500 microgram rather than giving 250 microgram in obese patient. Then the third important thing is about delayed trigger. So many times, what happens in patient, specifically in pure ovarian reserve patient, you are calling the patient on day 8 or day 9 of the cycle, and she is having follicle of, let's say, 16 to 17 millimeter. You may think that today I should not trigger, I'll let the follicle go beyond 20 millimeter, and you call the patient after 2 days. By the time she comes, the follicle is already either luteinized or she is already ovulated. Why this happen in this particular patient? This patient will be typically having a short cycle of 25 to 26 days, and her follicular phase is very short. So the FSH threshold is overcome very early by the ovulation induction agents or whatever the treatment protocol we are offering to them. And these patients is having gonadotropin surge attenuating factor deficiency. So because of that, the LH surge, which is controlled by this GNSF factor, that is not controlled in these particular patients, and that is why there is a faster recruitment. Now, if you are not giving trigger at 16 or 17 millimeter in this particular patient, her innate LH surge is going to happen, but that is inadequate for ovulation of that follicle. So the follicle just get luteinized, but the follicle doesn't ovulate. So typically in this patient, we say there is luteinized unruptured follicle. So in those patients, if you have this kind of a scenario, catch the follicle younger. Even on day 8 or day 9, the follicle is around 16 to 17 millimeter. The endometrium is good beyond 6 millimeter. Just give trigger rather than having this unruptured luteinized follicle. Many of the times, one of the mechanism is this. Or sometimes you have multifollicular development. No need of going till 19 to 20 millimeter for all these 2-3 follicles to go till that time. Because you just imagine all these 2 or 3 follicles are going to cause increase the E2, and as we know that if there is 200 picogram of estradiol for 50 hours, the LH surge will start. Now there are 2-3 follicles, the collective E2 is going to be more, and that is going to initiate her LH surge faster compared to monofollicular development. So when you have multifollicular development, still you give trigger early so that you should not miss that ovulation at that particular time of trigger. Second important thing is many times, last 6 months back, we just had this patient, that's why I'm discussing. Don't do your ovulation monitoring or confirm rupture once you give trigger. Because what happens that once you're calling the patient again, now there is a corpus luteum. Nobody can differentiate because the corpus luteum will be having a different way of degeneration. There will be hemorrhage, then the follicle will go away. But though the follicle is ovulated, it will also look like the follicle which is not ovulated, and they will label that you have luteinized unruptured follicle. If you have a doubt, anyways, if she is not conceiving this cycle, she is going to come on day 2 or day 3 of the cycle. Do a scan. If there are quite ovaries, means whatever follicle you have already seen that has ovulated. So avoid monitoring patient after giving trigger, because you are making patient also very sensitive, and you are all the time thinking that it is luteinized unruptured follicle. This was described by Sir, he has already well explained that LH surge is very different, for duration is also different, every cycle also it will vary, and it will vary along with the stress and other factors also. So timely HCG trigger is important, 17 to 18 millimeter and not at 20 millimeter, only in letrozole cycle, because the E2 takes some time to pick up. So in letrozole cycle, we prefer triggering at 19 to 20 millimeter. But if in clomiphene citrate cycle, or there is multifollicular development, better to trigger when the follicle reaches 17 millimeter. When high BMI patient, prefer 10,000 international units of HCG rather than 5. And recommend HCG, better to give 500. So follicle size at trigger, low reserve or advanced age, short cycle, better to give at 16 millimeter. PCOS or normal reserve, you can wait if there is a single follicle till 18 millimeter. If there are more than or equal to 2 follicles, then you can give trigger at 17 millimeter. This I am going to cover in tomorrow's trigger lecture, and sir has covered few of this, so I won't be taking that. Even modified trigger I'll take tomorrow. When you are taking any patient for ovulation induction, first of all, we have to tell them that specifically in PCOS patient, they will take 3 or 4 cycles. So you have to first let them know that your chances of having this ovulation induction timely intercourse cycle is going to be only 10 to 12%. You prepare your mind that 88% you are going to fail. I'm not putting a negativity in your case, but now your cycles are become ovulatory. For other girls, when they are trying with their ovulatory cycles for 1 year and they are still not getting pregnancy, then we are investigating for the reason of infertility. But now when your cycles are ovulatory, you have to be little patient about it. So when we talk about adjustment and infertility concerns, we have to focus more in emotionally approach and make them aware that we always plot that what is your success with TIC cycle, what is your success with IUI cycle, and if IVF, then what is your success. And it should be a cafeteria approach which is offered to the patient, and the patient has to change, because it is a shared decision making between a client and a doctor, that what suits for them depending on their emotional situation, depending on their financial situation. So viewing infertility as a threat or loss is a cause of distress, and when we see it as a challenge, then we increase the well-being of the patient as well. And it is always a blame or self blame or isolation when there is no pregnancy. But with all this information, when we counsel the patient, they are ready for preparing themselves for the worst result also. So cognitive restructuring and focusing on positive is always better. So it's not about just starting the prescription. We never write any prescription in first consultation with letrozole or any other ovulation induction. First has to be a counseling, psychological support to the couple, making their stress points to understand, and then going for further therapy is going to have a greater impact. So I'll move towards IUI. I'll just take few slides of IUI because when it comes to non-IVF, we should, along with ovulation induction, we should cover this as well. This is just to give an idea that whenever we are doing IUI cycle, we have natural cycle IUI though is out of question. But whenever we are doing IUI, we are not doing with ovulation induction agent because with this particular diamond study that when they have given letrozole, clomiphene citrate and HMG in unexplained infertility, they have a good live birth rate in HMG group, that is around 32.2%, in clomiphene citrate around 23% and letrozole 18.7%. The physiology behind is the same, that you have multifollicular development, the collective ETU is beyond 500, you have good endometrial thickness because you have multifollicular development, and that will increase the success of IUI. So all our gonadotropin IUI, all our IUI cycles are only with gonadotropins. The first protocol what we follow, as we mentioned, that if he is a high responder for donor IUI cycle or unexplained infertility, is to giving 2 doses of gonadotropin along with HMG. If the patient is poor responder, a low ovarian reserve patient, you can give clomiphene citrate along with 2 HMG also. Like you can see whether the patient is towards unexplained infertility or with low reserve. Then with low reserve you can go ahead with clomiphene citrate and HMG. Then in patients, if they are not responding with 2 cycles, means not responding means terms of they are having only monofollicular development, and when you are chasing multifollicular development, then you can have gonadotropins either alternate day or for day 4 continuously, and then you can have multifollicular development and go for IUI for trigger. So this I have already explained. So what are the predictive factors of pregnancy in terms of IUI? So PCOS, and if there is a cervical factor, then IUI works better. If your total motile sperm concentration, sir is going to take lecture of male infertility. So we never rely on what is there in semen analysis report. We calculate total motile sperm concentration, that is sperm count into volume into progressive motility in percentage. The better result of IUI when TMSC is more than 10 million, but even if it is more than 5 million, still it's a better predictive factor. Age less than 30, when you have 2 follicle beyond 16 millimeter, collective E2 beyond 500 and HCG trigger, and there is minimal intervention when you are doing IUI, and when you use soft catheter, the IUI success rate are better. Now, when in particularly in unexplained infertility, there is always a dilemma because she is already ovulatory. Your ovulation induction agent, there is no point of giving because she is already ovulatory. So you can either think about COH TIC cycle or COH IUI cycle. So, and there is many studies been published that if unexplained infertility reason, why not to go for experimental management rather than going for any intervention. So first intervention in unexplained infertility is IUI. So they have compared experimental management in IUI in unexplained versus IUI in unexplained infertility. So they had waited for 6 months with experimental management, and IUI 6 cycles were done. 180 couples with experimental management and 360 couples, they withdraw from study. So in expected management, the live birth rate was 13% and 33% in IUI group. So women who's less than 38 years of age, lower live birth rate in patient with expected management than IUI. But if the patient is more than 38 years, they expected management versus IUI didn't make much difference. So if you want to take any patient for for unexplained infertility specifically, expected management and IUI will be having same result. But if it is less than 38 years, rather than wasting the time, it's better to take them for IUI to have better success. Now, when they combined of doing IUI with FSH dose stimulation, I think our main thing is to have better response, and we start with 75 IU, then increase the dose, and then you can go ahead till the time of multifollicular development. Normal response what we want in IUI is 2 follicles of more than 15 millimeter. If there is a hyper response, 4 follicles beyond 15 millimeter and many follicles beyond 11 millimeter, then we have to think either to cancel, or I'm going to discuss tomorrow about modified Lupride trigger and how we can still not cancel and have a better success rate. And hypo response, that in spite of giving gonadotropin, you are not having recruitment more than 1 follicle. Now, so modified Lupride trigger, let's say you had given gonadotropin and suddenly you are seeing follicles which are now 3 to 5, and now you are worried about OHSS. But patient has already taken efforts and she has taken already so many of gonadotropin, and you are suddenly telling that don't have intercourse, I'm giving you agonist trigger because you will land up into OHSS. So then you can give this modified Lupride trigger in the agonist trigger in 3 different doses. Yeah, so like every 12 hourly 1.5, 1.5 and later 1 ml. So your every agonist injection is going to increase the FSH and LH. So the LH is not dropping down after what we see in our routine agonist trigger, and it maintains the LH level, and that is why it will ovulate, make the follicle ovulated. But we have like almost done 100 of cases with modified Lupride. None of them had gone into OHSS, and we are giving dydrogesterone for luteal phase support, where it is not measured as serum progesterone, but when we have done their progesterone level after 8 days of the trigger, they all had very good progesterone level that is beyond 25. So it is worth doing that modified Lupride trigger rather than cancelling the cycle when the patient has taken so much gonadotropins. So as you are saying, that it could be asynchrony when we are taking the patients with either for TIC cycle or IUI cycle. And very difficult to have synchronization in IUI cycle because all of them are going to come in day 2 or day 3 cycle because she has taken some treatment in previous cycle. So E2 pre-treatment and all these things we are not going to do in IUI cycle. So when these patients come, already there is FSH innate rise, which we just have learned in our previous lecture. And when we are starting with the gonadotropin dose, obviously there could be a synchrony. Some follicle could be already 19 millimeter, but rest other follicle could be 16 or 14 millimeter. Now you want both of them to go to have multifollicular development to have better success of IUI. In this patient, then you can add antagonist, continue HMG till the other follicle reaches beyond 17-18 millimeter, then you can give trigger. So this is one way, but when they have done, this is mainly to prevent the premature LH rise because of the leading follicle. As we were discussing, that if the leading follicle is beyond 18-19 millimeter, it will have luteinization or LH surge. But when we want to catch the younger follicle also along with the leading follicle, then we can add antagonist. That antagonist won't allow the luteinization of the leading follicle and allow the other follicle to grow, and then you can decide the trigger. But there are studies been quoted for about IUI in antagonist cycle, and they have seen there are no better outcome when we add antagonist. It is just going to have additional cost increment in the patient. But there is, if you add anta without anta, there are no much difference in terms of pregnancy rate in comes to IUI. You can add IUI when you don't want to do IUI in your Sundays. Let's say only for scheduling purpose. That is just to ease your way out, where you want to give trigger on Saturday and not Friday. Then you can add anta and give that trigger on Saturday, so your IUI will come on Monday. So only for the scheduling purpose you can have antagonist in IUI, otherwise no great result. This was a very nice study by a Chinese author, Chen et al., about what should be the optimal lead follicle size when you have letrozole HMG IUI cycles. So they have nicely done 2 groups. One group where there is spontaneous LH surge, and another group without spontaneous LH surge. So sometimes when there is a spontaneous LH surge, we think that we should cancel the IUI because she has already had surge and will be having negative impact. So what they have done, though the lady is having spontaneous LH surge, they had given trigger but done IUI within 24 hours rather than doing after 35 hours. And in another patient where there is without spontaneous LH surge group, then they have seen what is the lead follicle has given a better success in terms of IUI. So in patients where there was without spontaneous LH surge and they had given trigger, the optimal lead follicle size with better odds of clinical pregnancy was between 16 to 18. Again, it is mentioning that catch the follicle younger rather than waiting it for longer time. So your HMG cycle IUI will work better if you are giving trigger early. Same way, those patients who are having spontaneous LH surge. So if you see, there are patients who are having follicle size even 14 millimeter, 16 millimeter, but still they had LH surge. But still the pregnancy outcome didn't differ when they have done IUI within 24 hours. And between to 14 to 18 of follicle, they have same pregnancy rate. So again, it tells that no need of cancelling IUI on this basis. Give the trigger early and you still have looking at the better success. This I have taken. So again, the same thing, like whether we should cancel our IUI on the basis of thin endometrium in IUI. So this was very nice paper published by Weisman et al. That how thick is too thin, and whether we should cancel IUI on the basis of thin endometrium. Again, it's better to see in the mid-luteal phase, and if the endometrial thickness is good. The thin endometrium actually applicable to patients when we are taking them for IVF. And in those patients also, when you are giving, when you are starting a conventional ovarian stimulation protocol, and you have multiple follicles on the day of trigger, a very high E2 level, and still on the day of trigger you are seeing low endometrial thickness, then maybe we are looking at thin endometrium case. But otherwise, in terms of IUI or ovulation induction, it's not going to matter. About generalized agonist trigger, I already mentioned. When they have done a study about, I'll just skip this one. When they have done a study, this is a Canadian study, and what is the success rate of doing IUI after failed IVF cycle. So in Canada, the first 3 IVF cycles are sponsored, like insured rather than sponsored, but then later on the IVF cycle is not insured. So they have done a study, those who have failed initial IVF, and if we take them to IUI, whether still we have any hope of getting a pregnancy. So no difference in IUI success after 1, 2 or 3 failed IVF cycle. Patients where their age was less than 35 years, 10.5% success. Between 35 to 39, 13% success with clinical pregnancy rate. And more than 40 years, even 5.8% still have a pregnancy rate. So IUI success in women with less than 35 years, strong indication of IVF, and that's why maybe in less than 35 years, after post IVF fail, the success were lower, but more than that, the success were better because the indication could be only because of low uterine reserve or long duration of infertility. No woman beyond 43 years conceived with IUI. That again is a take home point that when the advanced age, it's not going to have much success with IUI. First IUI, 4.2% success rate. So there is always, we have to counsel the patient, there is no dead end, means like once the IVF failed doesn't mean the second IVF, because we always think this is the best treatment, your time to pregnancy interval is decreasing, but all of us should accept that the IVF success is not beyond 40 to 50% when it comes to live birth rate. When we are having failure after that, again putting the client into IVF because we don't have any other option is wrong. So we always should see what indication we have done. Obviously you are done for tubal block, bilateral tubal block, you don't have any other chance. But if it's other indication, you should give a thought of doing IUI rather than taking the patient for IVF. Semen preparation, we know that swim up and density gradient, but nowadays maximum we do density gradient only. If the patient is having normospermia, you can go for swim up technique. If the patient is having high DNA fragmentation, then microfluidic technique can be preferred. This Aphrodite group sir is going to take in his lecture. So whenever, when we know that we have a situation where the total motile sperm concentration is less than 5 million, then whether we should cancel the IUI or is there any option. If the wife parameters are good, she is young, she is having very good ovarian reserve, and her she is ovulatory, she is a very good responder. In those patients, you can ask take 2 samples with short interval, and when the TMSC is more than 5 million, then you can go ahead with IUI rather than cancelling on that basis. So this particular paper is telling that if the TMSC is very high, let's say your IUI success are going to be better till the time the TMSC is 20 million. But if it is beyond 20 million, whether it will hamper the IUI success. And they had given an explanation that when you have a high sperm count, that time the density grading method or centrifugation will release lot of ROS, and that may hamper the acrosome reaction or capacitation from the sperm, and that is why if you see in this particular graph, there is lower success of IUI when there is a high sperm count. So whether we should dilute the sample, but there are no studies available that when there is a high sperm count, you dilute the sample and take smaller sample to increase the success of IUI. This I'm not talking. So about sperm count and IUI success. So the same thing. If you are high sperm count, whether we should dilute the sample and do double IUI or with 2 semen collection. If there is more than 30 million, we should always look upon that this will increase more amount of ROS. Now, whenever we are doing IUI, we always worried about we have to keep the sample at 37 degree, and if we are not keeping at 37 degree, it may affect the sperm quality. So even after processing the IUI, we keep it in the under the laminar flow in the same temperature. But this was a very nice study. What is the influence of temperature and sperm preparation on the quality of spermatozoa? So they had done both techniques like density gradient and swim up technique, and the sample was kept at room temperature 24 hours, and in another group they had kept it in the incubator, and they had seen the result. So if you are keeping the sample at room temperature, the pregnancy rates are better, and there is better motility and decreased apoptosis in this particular sample. So loss of motility and increased apoptosis if you are incubating sample at 35 to 37 degree. So no need of putting the semen sample once it is processed at 37 degree. You can keep at room temperature because of this particular reason. Sperm incubated at lower temperature, they adopt a resting state, preserving their energy for acrosome reaction. And this is important when there is a time interval between the sample is ready and then you are doing IUI after some time. Incubation of sperm at 37 degree more than 2 hours, there is large nuclear oscillations which appear, and that may affect the acrosome reaction. So at Gallop et al. 2019 proposed that activation hypothesis, the sperms in vagina and uterus at 37 degree get hyperactivated, and that will affect the acrosome reaction in this particular patient. So progressive motility and morphology was significantly higher after incubation at room temperature compared to 35 degree, and the proportion of acrosome reacted apoptotic and dead spermatozoa were significantly lower in sample incubated at 24 hours at room temperature compared with 35 degree. So significantly better and longer preservation of sperm quality when they are incubated at room temperature rather than more than 35 degree. Then about high DNA fragmentation, we have microfluidic technique, where motility and morphology both were better after microfluidic sorting, and those patients who are having high DFI, in these patients we can go for this particular technique, where we have this kit which is available, and we have to keep the undiluted sample, and whatever at the end with that 4 channels, the sperms which are getting collected, they are having least DNA fragmented. The only drawback is sometimes this volume is very small, so again you have to put the sample, and again you have to wait for another sample to come over. So samples with large debris, high sperm DNA fragmented samples can be processed by microfluidic. Sublethal damage due to centrifugation is completely avoided because we are keeping undiluted sample. If motile sperms are very less at the end chamber in microfluidic from unsorted outlet, we can put back the semen inlet for one more round to have more motile sperm at the end of it. Now, what should be the abstinence? And this is a very common question. Sometimes even the embryologist will sensitize that patient that you had abstinence only for 1 day, you had abstinence for 7 days, and what will the impact on sperm count? So this is a very nice study that ejaculatory abstinence period on fertilization and outcome in ICSI cycle. So WHO 2021 recommended 2 to 7 days of abstinence before going for semen analysis, and 3 to 4 days abstinence by ESHRE. But short ejaculate abstinence is better than long abstinence for better viability and motility, decreased sperm concentration and seminal volume. So a gap of only 1 day will be more than enough. Even 2 days will be more than enough. Longer interval will affect the viability and motility of the sperm. There will be high oxidative stress SDF with long abstinence. And Motion et al. In 2010, higher pregnancy rate with less than 2 days abstinence at IUI than more than 2 days. So in our practice, what we say that many times the couple asks, or they think that we have to do IUI, so they don't have intercourse till the time we are asking them to come for IUI. So we always tell them, do you have regular intercourse from day 8 of the cycle? On the day of trigger, they can have IUI. The next day, ask them to have abstinence. And then on the day of IUI, they can give sample. That will have a better progressive motility, and the total motile sperm concentration also will be better. Then whether we should confirm ovulation before going IUI, and this was paper which talk about ovulation before or after IUI insemination does not affect live birth rate. So they have studied many cycles of IUI, and they saw there is no difference whether you confirm ovulation before IUI or if don't confirm the ovulation, the pregnancy rate in both the groups remains same. Then this was very nice, take-home message. Like when we are doing IUI, how we can improve upon IUI success. We have seen lot of parameters. This is one parameter that improving IUI success by performing slow release insemination and a patient-centered approach in insemination program with partner semen. So this was a study done in COVID. So before COVID, doctor used to do IUI, and obviously they were so busy that they had to go for pickup and they had to go for laparoscopy. So they used to come and immediately push the sample and it would go off. But later on with the COVID, when the nurses or midwives started doing IUI, so bolus IUI by doctors prior to 2016 compared to slow release IUI by nurses after 2016. So bolus IUI in 5 to 10 seconds versus slow over 45 to 60 seconds with 20 minutes of bed rest had improved outcome in terms of IUI success rate. So they have typically a song sung when they are doing IUI, and the midwife will put the IUI sample very slowly, so over a period of 45 seconds, and that will create that atmosphere better and that will improve. So they actually had that data that after 2016, if you see with slow release IUI, the success rate were better. Now, again with the same thing, that when you have a low total motile sperm concentration, it's better that you have a double ejaculation, combine both the sample, and that will improve upon the result. Short versus long interval, we just now said that this is not from the abstinence point of view. This is when your semen sample is ready, and then how much time you can wait, and whether that will have an effect in terms of clinical pregnancy rate. So short versus long time interval between semen collection and intrauterine insemination. More than 180 minutes of semen collection to IUI interval, or as soon as possible after semen collection. The clinical cumulative pregnancy rate after 6 cycle, with long interval or short interval was 51.4% and short interval was 39.4%. So it doesn't make much difference. So initial the concept was do IUI within 100 minutes. It no longer holds true. You can still, if there is any issues, you can still do IUI later, and that is not going to have impact on the pregnancy rate. Now, many of the time, even the patient reads about semen analysis report and the morphology is 1%, 2%. They're going to ask the question whether this morphology is going to affect IUI outcome or in terms of IVF also. So they have done nice study whether morphology will impact any outcome in regards to IUI. And this was a meta-analysis published in 2018. Which says there is no clinical pregnancy rate difference with normal or abnormal morphology of sperm. Abnormal semen morphology alone should not exclude coupled from attempting IUI. Means 1% morphology is there, we can't say that you have low success of IUI, because if you see it is more amount of TMSC, and TMSC doesn't take into consideration about the morphology. It is only count, motility and the volume. Then whether to give rest after IUI or not, and this was a study whether 10 minutes bed rest after IUI, and they have found that if the uterine cavity will act as a reservoir, so rather than immediately asking the patient to go out of bed after doing IUI, the 10-minute rest, which is very simple to do after doing IUI, that will act as a reservoir, and sperms are slowly released into the tube, and that will have a better result. And if you see the graph, the cycle number along with the cumulative pregnancy rate, it is better when there was increase in the time interval of bed rest after doing IUI for 10 minutes. Now, I had not taken HCG, when to do, trigger and all. I'm just summarizing all these practical points, not quoting paper at all here. Urinary versus recombinant HCG trigger in IUI, no difference in clinical pregnancy rate. No benefit of adding antagonists in COS IUI cycle. Trigger IUI interval can be flexible from 36 hours to 48 hours, anytime you can do IUI. Double IUI, no clear benefit versus single IUI, in any case. Sometimes in patients with initially we used to do donor IUI patient because because of the indication of azoospermia, we are doing donor IUI sample. So that time we used to do double IUI, but now even the donor semen sample cost is so high. So again, it's not making much difference between single to double IUI. So single IUI is preferable. No need of scan to confirm rupture to plan IUI timing. Luteal phase support has to be given in IUI cycle when we are thinking that it is more than 2 follicle. It has to be supported with luteal phase. No bed rest required post IUI, like resting for longer time. 5 to 10 minutes of rest after IUI is more than enough. Maximum 3 to 6 cycles of IUI. Clinical pregnancy rate better in first 3 or 4 cycles. After that, the pregnancy rate comes down. So not beyond 3 to 4 cycles of IUI, then you have to think of another intervention. So these all points have many studies which we can give as a proof, but this we can summarize, like now I just summarized and focused on another points we should discuss. Thank you so much for patient hearing.